So I'll be talking about vascular anomalies specifically within the field of pediatric and adult interventional radiology. Um, and I'm just going to give you some background on this field because I think it's pretty exciting when you know the history of this. So in 1971, Dr. Judith Folkman, who's a surgeon at Boston Children's at that time, published tumor angiogenesis at the New England Journal of Medicine, and it was the first paper to ever describe tumor angiogenesis. This was a breakthrough in the world of cancer, obviously, that we still relying on till today. And this stimulated a lot of research in vascular anomalies. So he recruited one of his co-residents, and that was Dr. John Mulliken. Both were residents at MGH, and basically told him, I need you to figure out all these hemangiomas. There's something behind them that is intriguing, and we need to know more about the pathophysiology of the hemangiomas. At that time, we didn't know anything different than just hemangiomas for everything. And Dr. Mulliken looked at about 49 lesions and figured out that there are at least two big groups that we can classify these lesions to, and these are tumors and malformations. And this landmark paper that he published in 1982 has been cited more than 5,000 times now. It is basically the mother paper for all the vascular anomalies. 14 years later, the International Society for the Study of Vascular Anomalies, the ISVA, adopted this classification. We're still using this classification until today. And this is the ISVA classification. This is the 2014 version, and the new version will be out hopefully this year. It will be revised. It will still have the big category of tumors versus malformations, but they'll be adding more diseases and some additional insights. But tumors versus malformation is a big deal when it comes to vascular anomalies. And the most common example of a tumor would be the capillary hemangioma that you see on the faces of some of the babies, and that it can resolve on its own, versus the malformations, which we all know, the capillary, lymphatic, venous, AVM. These are considered the building blocks for many of the complex vascular anomalies, which is beyond our talk today. But in general, tumors versus malformations is something that you want to understand if you want to do vascular anomalies. So for tumors, there's always proliferative component. They're typically sporadic. They have phasic growth, so they can be small initially, they can grow, and then they can involute as infantile hemangiomas. They can respond to chemotherapy. They might not be evident at birth, again, such as the infantile hemangioma or other types of tumors, and they can spontaneously involute. When it comes to malformations, by definition, they have to be present at birth. There's normal cell cycle. They can be sporadic, genetic, or part of a big syndrome. They typically grow proportionately with a patient. They don't respond to chemotherapy, and they don't spontaneously involute. An example would be lymphatic or venous malformation. Well, Dr. Pat Burr is one of the trailblazers of pediatric IR, and probably one of the first IRs to be involved with vascular anomalies. Was able to work closely with Dr. Mulliken and Dr. Fishman at Boston Children's, and they built a world-renowned vascular anomaly center, and also they wrote the Bible on the vascular anomalies. This is the book if you want to learn about vascular anomalies, and it's still considered the reference for vascular anomalies. And terminology continues to be a problem even today, even after all the studies and the publication, the work has been done. The literature continues to use incorrect terminology. And this is a study that Dr. Mulliken and his group did. They looked at all the publications that used the term hemangioma in 2009, and they found that the term hemangioma was used incorrectly in 71%. This is literature, this is not clinical practice. And then the interesting part that if you are incorrectly diagnosed, there's about 21% chance that you can have incorrect treatment, which is not a small number. And they also noticed that the wrong use of hemangioma was independent of the specialty, whether it's internal medicine, radiology, surgery, everyone used the term hemangioma to some degree incorrectly. I'm going to talk about a couple examples of malformations. This is lymphatic malformations, which is a regional maldevelopment of lymphatic channels. Lymphatic channels typically are tubes. So when they're maldeveloped, they form cysts and lakes. And this is typically due to a somatic PIK3CA mutation. So it's not a germline mutation. So if you have one lesion, it's typically just only one, and it involves region of the body and not multiple areas unless you have a syndrome or a germline mutation. And the common sites is the neck, axilla, and the pelvis. 50% of these are evident and seen at birth. And by age 2, 90% of these lesions will be evident clinically. Again, by definition, these are present at birth, but they might not be evident right away. The complications, they can have intralesional hemorrhage, they can get infected. If they're surrounding bones, or for example, around the jaw, they can cause bone growth abnormalities. And they're divided into macrocystic. That's when you see a cyst with fluid and could have bleeding. Like in this example, there's fluid level due to bleeding. So that's hematocrit level. Or they can be microcystic. That's when you just have diffuse, tiny cysts that you can see with imaging, but usually present as echogenic tissue. They can involve the skin, and that's when you get cutaneous vesicles, and these can leak or bleed. When they bleed, they become dark or red. They start clear, but then they become red with time if they bleed. Or you can have combined LM with other malformations, or you can have central conducting lymphatic anomalies or bone lymphatic disorders, which is beyond our scope today. The treatment is typically sclerotherapy. They respond very well, as Dr. Hernandez showed an example. Medical treatment with sirolimus was a life-changing treatment for many patients who are not amenable to sclerotherapy, either due to extent or other reasons. And it was a life-changing because it did improve the quality of life of many patients. It's become an almost standard treatment now for many conditions that are not treatable with surgery or with sclerotherapy. Surgery is not really an option for most of the lymphatic malformations anymore. It used to be done much more often, maybe 2 decades ago, but it was proven to be technically difficult. There's a lot of complications resulting from nerve injury, for example, facial nerve injury. You can have persistent edema after the surgery. You can have prolonged leak and delayed healing. And more likely than not, you can have incomplete resection and recurrence. So surgery is not a good option anymore for lymphatic malformations. This is an example of a cervical lymphatic malformation on a 2-year-old. This is what they look like, the fluid-filled cysts. On ultrasound, again, they look like cysts with septations. Depends on how complex they are. And this is what it looks like on physical exam. And if you don't treat this, this will keep putting pressure on the jaw, and then it will cause a long-lasting deformity. So typically we treat these as soon as possible, as early as 6 months of life. And this is after sclerotherapy, and you can see the cyst is almost gone, and the kid looks almost normal. So moving to more complex, I wanted to show you 2 spectrums of vascular anomalies. The one that I just showed was extremely simple, and now we're going to move to the more complex syndromes. And Klippel-Trenaunay is probably one of the more famous syndromes that we deal with, and it's part of a big group we call PIK3CA related overgrowth syndromes. All these syndromes are typically presenting with some sort of overgrowth, some sort of limb involvement or more, and they are due to a mutation in the gene of PIK3CA. So with Klippel-Trenaunay, you get several manifestations. You get typically a lower extremity, could be unilateral or bilateral, plus minus pelvic or GI or GU involvement when it goes up to the pelvis. The problem with Klippel-Trenaunay that it can cause pulmonary embolism if you have untreated marginal or sciatic vein, and these can be fatal, and it can present in about 15 to 22%. They can also cause recurrent bleeding, either from lymphatic vesicles, or if they involve the rectum or the GU system, they can cause bleeding from these systems. Also, these scattered lymphatic, cutaneous lymphatic vesicles in the skin can be a port of entry for infections, and they can cause cellulitis, which also can be fatal. So treatment for these is multimodal. The IR involvement with these typically comes with several layers of treatments, but most importantly is to close these big anomalous veins. So this is a 23-year-old with Klippel-Trenaunay. You see this capillary malformations. You see the scattered cutaneous lymphatic vesicles with bleeding. On MRI, you can see the difference between the left and right. There's extra fat. There's this huge vein that we call the marginal vein, and this is an embryonic vein that should disappear by the time you're born. But if you have the mutation, then it stays. And it's massive enough that when this patient stands up in the morning, they become dizzy because of hypotension and blood pooling. So the other feature of these veins are valveless. They can collect a lot of blood, and they're directly communicating with the deep system, so they can cause DVT and potentially PE. So what do we do with these? We close them as soon as possible for several reasons. First, we're going to prevent the DVT and PE. Second, we're going to improve symptoms, typically pain and swelling. And then the third thing, we want to force the blood to go through the deep venous system. So in this example, in angiography, you can see this big anomalous vein that becomes a marginal vein on the outside of the thigh. And if you follow this vein, it becomes a sciatic vein that drains through the inferior gluteal vein. And these are huge veins. And remember, this is with the patient being supine. When they stand, these veins can be double or even triple the size. So the way we treat these are several ways to treat these veins, but most importantly, you need to disconnect the vein from the deep system as high as possible. And in this example, we're using large coils, wires, and we're using this is in the times where we have bird-nest filters, and we're using that as a stopper for the coils. So once you disconnect the deep component, then the rest of the superficial component can be treated with either ligation or laser or RFA. So you treat these endovascularly. And then right after we did close the marginal vein with all these coils, you can see now the deep system taking the blood like it should. This is another example in a toddler. Again, Klopotronani, big leg, capillary malformation. This is angiography. This is the left side. We're injecting the dorsum of the foot, and naturally the blood wants to go through this anomalous marginal vein that is extrafascial, basically. It's not running inside the muscle, and then eventually it turns down and it goes to the inferior gluteal vein again. And if you look closer, there is very faint flow through the deep system, which you want the blood to go through the deep system, but in this example here, it's going all through this anomalous system, which is big, and it will cause swelling and also would cause potentially DVT and PE. So the way we close these, again, we disconnect the deep component with coils typically, and then we treat the outer portion with, in this example, we treat it with laser. You don't want to put coils right under the skin. And then right after we close the vein, you can see the blood naturally wants to go through the deep system, the popliteal, femoral, iliac, as it should. So the bottom line, we need to treat these as soon as possible, early in life, to force the blood to go through the normal system. And I think I'm going to stop here after my conclusion slides. I don't think I have time to go through the AVMs. But so as a conclusion, misdiagnosis is pretty common in the vascular anomalies ward, and the majority of the patients present to us with incorrect diagnosis. I would say in our practice, only about one-fourth of patients come with the correct diagnosis by the time they reach us. Misdiagnosis is crucial because it can lead to inappropriate treatment. Pediatric IRs are experts in diagnosing and treating vascular anomalies, and this experience can be transferred to adult vascular anomalies. So in our center, we treat both pediatric and adult patients for vascular anomalies. And then it's crucial to have multidisciplinary approach to get the best outcome. Thanks, everyone.
Thank you so much for that very informative lecture. It looks like we have one question in the Q&A. It says, what's your preference on vascular malformation on pediatric population, alcohol or bleomycin?
Oh, yeah, that is a very big question because, it depends really what you're treating. There's no single agent that you can use for everything. So it depends on what you're treating. I'm going to give you an example. If I'm treating a lymphatic malformation, there's a lot of variation in the literature and the centers of what they use, but the common agents will be doxycycline, bleomycin, alcohol, even citronellol have been used. But if you're treating microcystic LM, that's when you really need to use bleomycin because that's the only one you can inject interstitially. Another example, if you're treating a malformation next to airway or in the orbit, you want to use an agent that doesn't cause a lot of inflammation. So you would use bleomycin typically because that's the agent that causes the least amount of swelling. If you're treating an AVM and you want to treat without embolization, you want to just use an agent that doesn't stay, it's typically alcohol. You can't use other agents. You can embolize with glue, you can inject bleomycin interstitially, but because the blood moves quickly through the AVM, you need to use an agent that's very powerful, such as alcohol. So it's really a question that takes an entire career to answer, I guess, when it comes to malformation. So that's a good question.